Hello, everyone. Welcome. We're just going to let a minute go by so everyone can join from the waiting room, and Dr. Ashmore will be here in one moment to start his presentation. Thank you so much for joining us today.
I'll be right back. I'm going to go grab him.
We do have the chat open, so if you'd like to introduce yourself, say hi to the other participants, please feel free to do so. And there's also a Q&A at the bottom of your screen, so you can ask questions either anonymously or anonymously, and we will try to answer as many as we can. Just a quick note on questions. We did receive a number that were asking for help finding genetic testing or maybe a aortic doctor or provider, or other medical related questions, and we're not going to be able to get to those today. But we do want to help you, so please contact us. And I have Bella here to help with that. We are happy to answer those questions one-on-one, and we're going to share some resources. But Bella, would you like to briefly introduce yourself?
Yes. So I am Bella. I am the patient and advocacy coordinator for the John Ritter Foundation. I started almost a year ago, and my role is to help patients navigate the diagnosis, educate patients and their family members on the aortic dissection. So if you email us with questions, you'll likely be in contact with me. So please don't be scared to reach out. We're here to help you and figure out your next steps.
Awesome. And we'll put that email in the chat, but we also have a resource to share with you all later. And then just a very quick disclaimer, the information that's presented today is for educational purposes only. You should not change or make medical decisions based on anything that we're talking about today. This is to learn from, so please do consult your own team of medical providers if you have questions about your own care or your loved one's care. And then the last thing I'll say before I do the intro is to save the date, which is a bit in advance. We're taking a little bit of a summer break, but August 6th will be our next webinar with Dr. Takayama, who's going to be talking about how to make decisions about elective repair of aortic disease. So I know a lot of people are in that watch and wait situation, which I think we're going to probably talk about today too. So that will be a really good one to attend. And with that, I'm going to do a brief intro here so we can get started and you can hear from the person that you're all here to hear from. So we are very privileged to have Dr. Ashmore joining us today. He is the Chief Wellness Officer and Director of Medical Psychology at Baylor Scott & White, the Heart Hospital. He received his doctoral degree from the Ohio State University and completed his clinical training at Duke University Medical Center. His postdoctoral fellowship focused on the biopsychosocial, which I'm hoping we learn a definition of today, aspects of health behavior change in the context of chronic illness, including cardiovascular disease. He now serves as the Chief Wellness Officer for the Heart Hospital Enterprise and chairs the Physician Wellbeing Council. In addition, he's in his spare time, clinical professor in the Department of Medicine, where he trains students and supports residents and fellows. And on a personal note, I can say the three of us, Meredith, Bella, and I saw him speak recently at a meeting, and we're blown away by his presentation. So we're all really excited today. And I forgot to let Meredith do a very brief info. My apologies.
That is totally okay. Dr. Ashmore's the star. I'm Meredith O'Neill. I'm the CEO of the John Ritter Foundation, have been with it since 2021. I wanted to welcome all of you. So excited to see people literally from all over the world. We have somebody from Denmark who just commented watching today's webinar. I had a type A aortic dissection when I was pregnant in 2018. And something that when I speak to survivors, even some extremely high-powered survivors, what they say is the body was easier to repair, it felt, than the mind after. That the recovery time was shorter for the body than it was for the mind. So this is extremely important. And another piece was I went through therapy after my dissection, and it was extremely important to me. But one of the things that was most impactful to me was actually told to me by Jason Ritter. He said, it is okay to be grateful and angry at the same time. And I thought that was a really beautiful thing for him to say, to kind of give me permission to feel all the feelings I was feeling in that moment. I also wanted to personally thank Dr. Ashmore. He is at the hospital that I go to for my care. So always so grateful. I get to see him with the dogs around the hospital when I go visit. And this free programming, things like this webinar and the Aorta Advocates and Aorta Prep and the resources online and things like that are all free. And we're able to do that through generous donations from people like you. So if you're inspired by today, again, this is free. There's no, obviously, you don't have to give a donation, but if you're inspired by today, please consider giving to the John Ritter Foundation at johnritterfoundation.org, so we can continue to bring these really important webinars and information to you. So with that, since you already gave his introduction, I would like to pass the torch over to Dr. Ashmore.
Thank you guys for so many nice things. And I'll do my best to live up to the things that you're saying. So I want to make sure you guys can see my screen. Can you see the presentation? Let me try one more thing and then we'll move right on. I do want to comment on something you said, Meredith. You mentioned that you had been told, and you appreciated it, that that the body kind of heals faster than the mind. And I'm going to show one slide down the road. I'll talk briefly about it. This shows quality of life. When we look at quality of life, you measure it across several different ways. And physical functioning is one of those. And we see over time that quality of life with physical functioning after aortic disease, some form of aortic disease occurrence, that kicks back to normal pretty quick. Everything else lags behind. So I think what you're describing kind of anecdotally, we see in the scientific literature too. So I'm going to give up on that. If this looks okay, we'll just go with that.
It looks great.
And so what I hoped that everyone takes away from today's quick discussion is an understanding of the biopsychosocial model. That's a mouthful. That sounds awful. When Ellen mentioned it, I thought to myself, that sounds terrible. I need to change the name. But it makes the point. It's a complicated model. I hope that you'll walk away from today being able to differentiate normal distress from abnormal distress. We often over-pathologize each other and others, and we don't want to do that. Steps to get help if you need it. And I'm going to finish on a positive note. So stepping back, when you look at the general guidelines for the management of aortic disease, within the guidelines, they say, hey, we should be screening for anxiety, depression, PTSD, quality of life. So everyone who has been diagnosed or is in the process of being diagnosed with aortic disease, these should be taken into consideration. And for folks that need some resources, they should be provided. So every clinic, every provider that treats aortic disease, theoretically, based on the current recommendations, is that they not only need to screen, identify, but they also need to offer help, whether that's in-house or outside. With everything that we do in science and medicine, we always need to know more, and there's a general gap in knowledge. But I'm going to share with you what we know, broadly speaking, and hopefully not in too technical words. So the best practice assessment for someone struggling broadly with heart disease or an illness is the biopsychosocial model. And you see at the center of the model is heart disease, but you can put any disease in there. You can put lung disease, you can put diabetes. It doesn't really matter what the disease is, but broadly speaking, we're targeting disease. And as important, in my view, oftentimes, most important is quality of life. I think everyone on this call here not only wants to extend their life, cure any illness that they have, but not at the sake of quality of life. Everyone wants to have a high quality of life. So we're really looking at two things right in the middle: disease and quality of life. And to optimize heart functioning, broadly speaking, and to optimize quality of life, or to look at those things that affect heart disease and quality of life, we're looking at 4 domains or 4 main buckets. So the first bucket is biology, which has to do with anatomy, medications, genetics, pathophysiology, typically what your physician is working with. If you're a genetic counselor, you're working side by side with the patient and the physician to identify any genetic predispositions, and you're making some decisions based on those findings on what to do medically, biologically to help any one person. On the psychological side, or the psychological bucket, specific to heart disease, we're always concerned about depression. And the reason we're the reason why we're concerned about depression is because it feels lousy, right? It's quality of life. It affects our quality of life. But we also now know that depression is an independent risk factor for cardiovascular disease. It makes things worse. If you are clinically depressed, you're at increased risk for a second event like a heart attack. We know that it has a powerful direct and indirect effect on heart disease. Stress and related disorders, we know, are associated and a risk factor with these things. Anxiety, anger, irritability, agitation, and impatience. Some of you guys might remember type A behavior pattern or type A personality patterns. That was predictive of heart disease. Well, it turns out the pieces of type A personality behavior are how we experience and express anger, irritability, agitation, and impatience. The best way I can explain this is imagine standing in a line at a grocery store and the person in front of you is fumbling around. Are you someone who can just sit back and relax and just kind of take it as it goes? Or are you someone starting to get a little bit irritated, wanting them to speed up? If you're one of those like me who are wanting things to move faster, you're probably going to score high on AI kinds of things, which can be a risk factor. And then also, and lastly, in this psychology bucket, we're dealing with cognition meaning your memory and concentration. We know that's associated. The bucket or the domain below psychology is social. When we're talking about social, we're talking about social support, not the number of people, not the quantity, but the quality of social support. Loneliness, isolation, and marital satisfaction. A couple of years ago, 2023, the Surgeon General put out their paper on the United States epidemic of loneliness and isolation and how that affects health and quality of life. We know it's a powerful risk factor for health in general. And below social, you'll see a cigarette there. So I'm going to ask you guys in the chat, why do you think I have a cigarette there under social? And I can't see the chat, so maybe if you guys call out, Ellen and Bella, Meredith, if you call out what you're seeing.
I know. Ellen and I can. Oh, it says we have a no social smoking from Lisa.
Okay.
Ellen, if you want to do the last one.
Comfort, habits, depression is worse for you than smoking, someone said.
Okay, you're getting all good answers.
Smoking and drinking are social activities.
They are. Those are all correct answers. But what I'm looking at and put the picture there is to prompt me to remind me to mention the studies that have shown that lack of social support, loneliness and isolation is as powerful of a predictor of health as smoking cigarettes. In fact, up to 14, depending on the study, up to 14 to 15 cigarettes is estimated the effect of loneliness. So if you think about that, every time you go to see your physician, they're asking, are you smoking? Why? Because it's a risk factor for bad things happening to our health, specifically cardiac disease. How often do you get asked, how are things going on in your life? Who's in your life? How's your relationship? Are you lonely? Are you isolated? And if you're not, then you're not actually getting the best care from a biopsychosocial aspect based on the scientific data. Now, is it 14 or 15 cigarettes? Is that the amount of an effect that like social support has? I don't know how many cigarettes. That's debatable. But what's not debatable is that it is a powerful risk factor that we should be talking about and considering. This last bucket, health behaviors, it means exactly what it says. Health behaviors, those things that are good for us. Physical activity, diet, adherence to our medications, adherence to what your doctors are saying. So you can see this is a complicated model and all of these things interact. And what I'm going to show you, hopefully, here in a little bit of real life examples of putting this in action. So it really makes sense. Now, shifting gears and speaking specifically about aortic disease, the prior slide, the biopsychosocial model, and those domains and risk factors were broadly heart disease specific. And now I'm going to talk specifically about aortic disease and the common biopsychosocial comorbidities that are associated with it. It gets tricky because the different problems associated with aortic disease are vast, right? So it's hard, the data isn't real clear specific to each one. So what I did was pull the data broadly across multiple problems associated with aortic disease and give you a range of associated comorbidities. So for example, depression, we see about 20 to 32% of folks with aortic disease meet criteria for depression. Those key symptoms are sadness, the lack of pleasure in activities. That's anhedonia. Anhedonia is just a fancy way of saying lack of pleasure in activities you once found pleasurable, and then withdrawal. Anxiety, up to 50% of folks have anxiety at a level that would be considered problematic or toxic. Excessive fear, worry, nervousness, tension, panic symptoms. Postoperative decline, so your cognitive functioning, your memory, your concentration, your attention, processing speed, planning, decision-making, executive functioning, forgetfulness. About 10 to 40% of folks after surgery will have some declines in cognitive functioning. Typically, this is, and mostly this is temporary. We see functioning improve, but it's something we need to pay attention to and to help folks as they move forward with the physical recovery post-surgery. PTSD, as many of you guys can imagine, is pretty high, 20 to 23%. Those numbers are about what we see from veterans coming back from combat. So one could say or argue that with an aortic dissection, your risk for developing PTSD is equal to, at least, if not more, than being in combat in a war. That's a lot. That's enough to take notice and do something about. Those key symptoms related to PTSD are re-experiencing the traumatic event, avoiding things that remind you of the event, changes in mood and thinking, and hyperarousal or hypersensitivity. Then from a behavioral social standpoint, we see again avoidance, withdrawal, and the distress with marriages. Now, it's really important to take all of this into consideration, appreciating that the minority of folks struggle with these problems. And so when we talk about distress, psychological distress, we have to look at it on a continuum that ranges from normal distress to abnormal distress. And so, of course, when any of us go through something traumatic, whether it's a medical diagnosis or a medical procedure or anything else that we deal with in our lives, some level of stress, anxiety, sadness comes with it. And so being able to differentiate between what's normal and considered, hey, this is okay, just give it a little time, you'll wrap your head around it, to what we consider moving into an adjustment disorder, a distress response, anxiety or depressive response in excess of what we'd expect given the circumstances. That's starting to move into what we call psychopathology, which could be toxic. And then moving down the continuum would be more along the lines of clinical depression, PTSD, one of those diagnoses that then we think of as being pretty severe, a red flag waving to us saying, we better do something about this. This is needless suffering. Let's work on this. Let's fix this. So how do you tell the difference between what's normal and what's abnormal? You have to look at several things. One is the number and type of symptoms. The magnitude of distress, how bad does it make you feel? Is it just a little bit or is it a lot? I saw someone in here yesterday in my clinic, in my office, who became aware in the middle of a procedure, a cath, he was getting a stent, and he became aware and felt the pain, and that's not ideal. You don't want to be aware of a cath going into you and you're getting a stent or experiencing any pain. And so when he was describing that, he came in, worried that he had PTSD. He didn't. He had somewhat of normal distress given those circumstances. His level of distress, when we talked about it, was rated at about a 20 on a scale of 100. We wouldn't start thinking about distress until you're 70, more significant distress until you're about a 70 or above, and scores on measures were low. He's okay. It was just getting him through this and giving him some tips on how to get over that awful traumatic event, but not pathological event. So that was more in the normal adjustment range. Impairment in functioning, that's key, right? Before you can say someone has a a clinical pathological problem, you always have to ask, is this impairing your ability to function at work, in school, socially? Adherence, right? Is this a problem so severe that you can't adhere to your medical regimen or the things that you're being told to do? And then, of course, persistence of symptoms. So with any event, and we're talking cardiac events in this case, it could be a heart attack, it could be an aortic dissection, it could be a diagnosis or positive on a genetic screen. So whenever we have or go through an event, of course, we're going to have distress. And typically the stress goes up, and over time with doing nothing, we see that distress go back down to baseline. Turns out that about 20 to 30% of folks who have a high level of distress will not remit, will not go back down to baseline. This is the stuff we're concerned about. We're concerned about those folks. So our goal or our hope or idea is, are there things that we can do to minimize distress when an event is occurring or we're predicting an event is occurring? And then if and when it does occur, what do we need to do to help get back to baseline sooner than later? And then also, of course, catch these folks in that 20 or 30% and get them the care and the treatment that they need following general evidence-based guidelines. So this next slide, don't worry about reading the graphs and stuff. Again, this was to prompt me with making a comment based on what I already commented on, which was Meredith's. It was Meredith's comment about quality of life and physical functioning. And broadly, over time, folks who have had a dissection or an aortic replacement, 1, 5, 10, 12 and a half years, from a quality of life standpoint, is not quite as good as those who haven't had these problems. So quality of life decreases and maintains a decrease over time. Well, the type of quality of life, the physical related quality of life, we actually see that boost up quicker and maintain a little bit higher than the other aspects of quality of life, like pain, social functioning, mental health problems, emotional role, your vitality, your energy, those tend to stay low. So that's all I wanted to make a comment, that quality of life is important, and left untreated or not considered, it tends to stay lower than normal folks. So, gosh, I wish I had my big view. I'm going to try to get the slideshow again because it does a better job. It's not working.
Will it let you click on that resume slideshow?
Oh, wait, what do you see now?
We see it from the beginning.
Fantastic. Yeah.
You got it.
Perfect. Okay, so I am going to talk about a real person here. And can you see the slide?
Yes.
Okay, so this is a 50-year-old female, married, BMI 36, so struggling with her weight a little bit, works full-time, 2 teenagers, active person, active woman, diagnosed with a thoracic aortic aneurysm. Risk factors believed to be contributing to this was a genetic mutation and uncontrolled hypertension. Does that sound familiar to folks? It may be you, or certainly if you're a provider or a healthcare worker on this call, you've seen this type of person. So what do? Control our hypertension? Is that a focus, a treatment focus? Well, I wish it was that simple. It's not in this case. What seemed to be contributing to her hypertension was medication non-adherence. So this particular woman was not taking her medications in the way that she was supposed to. So what do? Tell her to take her medicines? I wish it was that easy. Turns out this woman was struggling with memory, forgetfulness. She was forgetting to take her medication. She wanted to take it. She was just forgetting to take it. So why would someone forget to take their medication? What would be causing forgetfulness or this cognitive dysfunction? In this case, untreated obstructive sleep apnea. So she had obstructive sleep apnea, was not wearing her CPAP, which leads to forgetfulness, cognitive dysfunction, which is leading to the medication non-adherence. So now we're thinking, really, look, it's a non-adherence issue. She's also met criteria for moderate level of depressive symptoms, so clinical depression at a moderate level. Driving that could be or appeared to be CPAP non-adherence. If you're not sleeping, you feel exhausted, that certainly makes you feel depressed or could lead to clinical depression. And she was busy with her teenagers, working full time, and work was very, very stressful. So in the chat, if this was a patient of yours or thinking about this particular patient, where would you intervene? What do we do for this person? What do we target first? So plug it in the chat. Just best guess. Give her an antidepressant medicine. And I can't see the
Sleep.
chat.
Someone says sleep,
Sleep.
weight loss,
Okay. Weight
sleep
loss.
apnea, CPAP adherence, someone says.
Yes.
CPAP machine with an exclamation point.
Yes. That is absolutely, that's what I did, right? There's not necessarily a perfect way to address such a complicated thing, but CPAP is the most parsimonious, the easiest one. So if we could get her using her CPAP to treat the obstructive sleep apnea, we then would hypothesize that we'd see forgetfulness decrease, the cognitive dysfunctioning decrease, depression decrease. That was the intervention point. Get used to that CPAP through exposure-based treatments. In fact, with that, we actually saw a lot of the problems resolve. So I'll move on to another example. So this is a gentleman, 70-year-old male, married, retired, volunteers, loves to spend time with his grandkids. No pre-morbid psychological problems. Pre-morbid is just a fancy way of saying, a psychological problem in the past before his type A dissection. So we had a kind of out of the blue type A, well, not totally out of the blue, but aortic dissection, living active and following, started feeling depressed. In fact, met criteria for a depressive disorder. What do we do with this person? Throw a antidepressant at him, or use the biopsychosocial model to learn more about this individual, to see what is actually going on. What is our best approach to treat this guy? So following the model, we find that following the dissection is very anxious, very worried. So if you think about anxiety is driven by the belief, right? So running in the background, whether you're aware of it or not, anxiety is driven by the belief there's an impending threat or danger coming down the road, right? This makes sense. It's a reasonable fear. Think of worry as the verb that kicks in once the emotion of anxiety happens. And worry is the cognitive or the mental process we use to cope or deal with or solve the problem of whatever we believe is coming down the road and the threat. And so what happens is something happens. We have the belief there's an impending threat or danger coming down the pike. We start to worry, and we tell ourselves, well, if I'm worrying, therefore this must be true. If I'm having anxiety, it must be true. It's this vicious cycle that spins. So for Mr. K, that led to behavioral withdrawal. Now he's withdrawn. Now he's not going out and doing the things that he once did. That leads to depression, generally speaking, and certainly in Mr. K. So once you start withdrawing from activities that you once found interesting, reinforcing, pleasurable, depression symptoms start to occur. One of the symptoms of depression in and of itself is behavioral withdrawal. So now we're stuck in this, starting to cycle here at this level. Guess what happened? He's not going out. He's miserable to be around. Now he's starting to affect his relationship, which increases his depression, increases the behavioral draw, and you can see here that we're starting to spin and cycle even more. Depression, one of the symptoms is sleep disturbance. Now he's not sleeping, he's even more tired, he's even withdrawn even more. So what do we do with this? What do we do with Mr. K? So in the chat, put in, what do we target here? An antidepressant medicine? Is that our first line treatment?
When I first saw this, I thought it was antidepressant, but we have therapy, CBT.
Therapy, perfect. CBT it just stands for cognitive behavioral therapy. Those are great, but where? What would we?
Exercise,
What's that?
exercise, outreach, hobbies, somatic therapy.
All good, all correct, all correct. For him, if you think about this model, what drove it all? What was the starting point? The anxiety and the behavioral withdrawal. So there's a two-pronged approach for this guy, which we took, which was help alleviate the anxiety, help this belief there's an impending threat, teach him how to cope with the fear that he's dealing with related to his diagnosis and illness. So address this issue here. And then at this behavioral withdrawal level, engage him in what we call behavioral activation. Just get out and start doing stuff. You're not going to feel motivated to do so. No one ever feels motivated to do so when they're depressed, but behavior precedes motivation, and we want to get him engaged back in life. With that, we often see the depressive symptoms start to become alleviate, which fits with someone who said exercise. Exercise certainly could be part of the behavioral activation plan. And part of the reason is it gets them out, but we also know that exercise is an evidence-based treatment for mild to moderate levels of depression. So all of the answers were great. Targeted anxiety and behavioral activation, and we started to see things remit. So as you can see, when you look at someone from the lens of a biopsychosocial model, it gets complicated, but it's worth taking the time and the effort to look at it, because you can really then hone in on what you need to address and where you would guide yourself if you're struggling with this personally, or if you're a healthcare provider, who and what should I recommend, and how should I recommend someone start moving in the direction that's going to help them the most cope with this unfortunate and awful disease and diagnosis. So with that, treatments in general, what do we do? Step one, obtain a comprehensive evaluation using the framework of the biopsychosocial model to help explore what specifically is needed for that person. And then always refer to or get evidence-based treatments. And that depends on the problem. Remember, at first we talked about wait and watch, because the vast majority of folks who go through an event tend to go back to baseline over time. So wait and watch is a fair assessment. But if you think there are things that you could do personally, or as a healthcare provider suggest for someone to do, some of the evidence-based treatments could be cognitive behavioral therapy, which was mentioned in the chat. Coping skills training, which is a set of strategies and behaviors and cognitive skills that falls under CBT that can be used. Mindfulness-based practices are extremely helpful in theory and evidence, science-driven. When it comes to post-traumatic stress disorder, there's several evidence-based treatments, and there's a whole lot of non-evidence-based treatments that I would not touch or send to anybody. And the evidence-based treatments that work are all driven by exposure, exposing the individual to whatever they are afraid of or concerned of. And you do that in a very systematic way. There's experts in this area. Marital therapy if needed. And then, of course, psychotropic medications are always an option, and a great option, and one that sometimes have to be used. But there's a lot of other things that could and should be used in addition to or before you jump to just throwing medicines at the problem, because that won't always take care of the problem. With that, as promised, I said I'm going to end on a positive note. And so if you take a look at that picture, you see me and a guy next to me. The guy next to me is Martin Seligman. Martin Seligman is probably one of the most influential psychologists of our times. I'll tell you a little bit more about him in a second. And next to Dr. Seligman is Gary Rubin, who's a cardiologist, and he was instrumental, one of the people instrumental in bringing cardiac stents and the process and procedures to put stents in to the market for approval in use. So probably folks on this call, they certainly, folks on this call either know someone or have experienced someone who, because of his work, had a treatment based on some of his work. And so I met these, and the woman on the side of Dr. Rubin is my old lab mate in grad school. We worked in the same lab together. And we met these guys at a small conference in New York where they brought the biology with the psychology. And it was really cool to see these two folks who were really founders of the field that we're talking about right now together, and to hear them talk about how biology and psychology intersect, just like we've been doing today. And one of the things Martin Seligman told us, and he tells this story often, is when he was a young professor studying psychopathology, right, the bad things, his young daughter asked him, why are you always focusing on this bad stuff? Why are you talking about depression, anxiety, all these bad things? And he said that struck something in him. And he started thinking, well, why are we not focusing on the positive aspects of what could lead to a happier, higher quality of life and health? That spurred on his study, decades-long study of positive psychology, focusing on the positive emotions that not only make us feel better and improve quality of life, but have an effect on health. And at this point in time, we have enough data to show that this is an intervention in and of itself worthy of pushing along to other folks. And it warrants a more study on the effects it has on health. And so what that intervention looks like, these interventions are designed to enhance positive emotions. So what is it that you can do as an individual, or if you're a healthcare provider, encouraging folks to boost positive emotions, enjoyment, love, contentment, amusement, any emotion that makes you feel good? That's a good thing. When it comes to engagement, that refers to getting in flow. Some of you may have heard of flow. This is a state where you're kind of lost in the activity in which you're doing. Mountain climbers will say they're in flow when they're climbing. They don't think of anything. They're just honed in. Surgeons will say, I'm in flow when I'm doing surgery. I'm engaged. I had a professor who, he said when he was writing, he would get into flow. If I'm mountain biking, that pulls the flow state out of me. Everybody's different, but trying to figure out what activities will pull you into that certainly is what's meant by this PERMA model, engagement in the PERMA model. Loving, close, trusting bonds with other people, fostering relationships. Meaning is gaining a sense of purpose out of activities, belonging to something bigger than just yourself, which isn't always easy to do, but striving for that can be beneficial. And then accomplishments. And this doesn't mean big accomplishments. This can be small stuff. This could be clean a room or get something done. So just getting the satisfaction. So the idea here is, and this is driven by the science, is that there's specific things that we can do. And if we're striving for positive emotions, engagement, relationships, meaning, accomplishment, or PERMA kinds of things, we're not only likely to improve our health, but we're certainly likely to improve the quality of life. So I say do both of these. I say we have to do both of these. We have to do a good, thorough biopsychosocial assessment to make sure we're catching any of the bad distress and intervening where needed. But at the same time, we need to be pushing ourselves, as well as the folks that we work with, to do more PERMA things. And I think if we're doing that, we're really pushing to optimal health, optimal quality of life. And with that, let's open it up to any questions. I think we have a few minutes.
Thank you so much. That was excellent. We have a lot of people saying thank you in the chat too. So I think you've lived up to our high expectations for you. There was some questions about support and meeting other survivors. So I really quickly wanted to just hopefully, oh, no, that's not the right one. Hopefully, no. There we go. Hopefully that worked. You're seeing a little box about accessing support and help. You can also find this on our website. This form basically goes to our beloved Bella, who can connect you with another survivor or someone else who's lost someone or someone else who's in the same situation as you, as well as access other resources that we have. So I encourage that. And then I will start with a question that I got ahead of time just to kick us off, but then we do have some as well in the chat and other places. And I thought this one was topical because I think a lot of our folks have expressed this to me before. I often have medical professionals tell me, you don't look like someone who's sick. I'm not sure why you're saying there's something that's still wrong. I hear it over and over. As a dissection survivor, I know I'm healed on the outside, but I still feel broken. How do I respond to that?
Yeah. So how do you respond? So I'm wondering if it's how do you respond to the provider that's saying this?
Mm-hmm.
You know, it depends on the provider. It's always tricky, right? Because oftentimes our physician providers are very, very talented at what they do and what they're trained to do, and they're not necessarily trained to help take care of the other side of things. And so I think appreciating that and trying to figure out, is this provider going to be able to take care of me on this side of things? If they are, then you can certainly ask them, no, I need more. And this is what I mean, and try to explain it. If you don't think that's a provider that you can do it, and I actually have a cardiologist that he is not going to give me any of this stuff. He's a technical dude and he gives me that, and I get that other side and social support and that other type of support that I need from another provider and then other folks. And so one, can the physician provide it? If not, then find your own resource. Ask that physician or provider if they could refer you, or use this type of a setting to find people that can help and give you the support. You're not alone. You're definitely not alone with those kinds of comments. It happens all the time. So lower your expectations of some of the providers and get the help somewhere else.
Thank you. There is someone in the chat asked, any recommendations for someone who is managing under watchful waiting? I struggle when I get twinges in my chest or neck and I stop and panic that a dissection may be occurring. And I know a lot of people feel the same way, who know they have an aneurysm or something wrong with their aorta, feel like, you know, people often say the ticking time bomb. We hear that all the time. So yeah. I think you are also not a lone person who wrote that comment. I think that's very, very common. So any tips there?
So the very first tip is, of course, reach out to your resources. Find someone locally that can support you through this time. That's a given, right? Someone that has knowledge and are able to help you through the anxiety that you're experiencing. And in this case, remember, I said anxiety is driven by the belief that there's an impending threat or danger. And this is a real impending threat or danger. So how do you cope with and manage that? And getting the help from someone can help you do that. The other little tip is always have a plan, right? And I think most folks do, and they work with a provider that can assuage some of the concern that if this happens, if these symptoms occur, this is what I do. So be armed with a little bit of a plan, but at the same time, go get some help that can help you cope with and tolerate some of the concerns.
Has EMDR, and maybe you can define that for us, been used in therapy? Is there data behind that? Is this useful to get through the event that triggered issues or prevent or minimize long-term effects?
Yeah, so EMDR, eye movement, desensitization, retraining. I think that's what that stands for. So as far as I know, the only evidence-based application of EMDR is for PTSD. The use of EMDR for other problems outside of what we know, it would be using a non-evidence-based treatment. Does that mean it wouldn't help someone? No, that doesn't necessarily mean it doesn't help someone. The research just may not have caught up. But what's typically thought of, the mechanism by which EMDR works for PTSD isn't the brain chemistry changes that is proposed by the theory. What we believe is that it's just more of the exposure base. So remember I said treatment of PTSD, all the current evidence-based treatments for PTSD are driven by exposure. So there's an underlying component of the exposure that's necessary. So EMDR outside of very specific PTSD treatment would not be my go-to recommendation necessarily. Again, that doesn't mean that it doesn't work. There's a lot of folks that practice and use EMDR. There's could be a lot of utility out of it, but that's the state of the research, I think, at this point.
Ellen, do you mind if I ask a quick question?
Please,
That
yeah,
comes
I
up a
saw you
lot.
go off. I was about to ask.
Yeah, in the chat. So, Dr. Ashmore, this is kind of a two-part question. I always say that I slept during the hardest part, which was the surgery, right? And I've always been extremely concerned about my family members, my caregivers, and there's been a lot of caregivers in the chat. And so my question is two-part. Number one, do you have any evidence around, and I might be putting you on the spot, but do you have any evidence around how these major cardiac catastrophes, if you will, affect caregivers, number one? And number two, do you have any tips on how to talk with your family members about their mental health after a big, because they're so concerned about you, sometimes they don't take care of their own mental health.
Yeah. So the first thing I always say about caregivers is that is one of the toughest roles to be in, for all the reasons you guys know and all the reasons you guys have probably experienced firsthand. And the stress of being a caregiver for anything is ridiculously difficult, especially in something as severe as an aortic dissection or aortic disease. So caregivers, hats off to you. It's hard. It's hard. It's hard. It's hard. So the effect is big and known and well known. You know, the same applies to the caregiver in that they're there to give support, but they also need support. So I always help the caregiver find the support that they need to get through it. And that's not necessarily on the person that they're caregiving. So that's kind of the second part of that. And I kind of forgot you had another, I'm not answering one of the questions. What was it? What
Just
did you
how do you have that conversation with someone, especially if they're resistant? Yeah. They're like, I'm worried about you. Let's take care of you. How do you have that conversation with a loved one?
Yep. So no one size fits all. Every relationship is different. You know your loved one, and you know the best way to approach them to help them. Probably if it's not going as hoped or planned, then you rely on the healthcare provider to make the suggestions and recommendations. And to the degree to which it's appropriate and your loved one is agreeable to you going on to those medical visits and sharing information, that's a way to kind of work around it too. There's no easy answer. Again, it's so different for everybody. But always ask what can I do for you? How can I help you? What's the best way I can help you? And if I can't give it to you, I encourage you, I support you. Tell me how to help you get the support that you need, whatever it is. And partners aren't always the best people to give the support. In fact, they could be the worst at times. That doesn't mean you're not a great partner, doesn't mean you're not loved, doesn't mean you're not appreciated, you can't do a lot of stuff, but it just means that for that particular need, you may not be the person. And that's okay.
Do you want to chime in?
I actually had a question. So I forgot to say it earlier, but I am also personally affected. I have one of the genetic conditions or the genes that increase the risk for aneurysm and dissection. I have vascular Ehlers-Danlos syndrome. And I tend to do a lot of distraction to help my anxiety and keep my mind at bay. And you were talking about the flow and getting to the flow where you kind of just get yourself lost in whatever you're doing. But I also know that distraction can be considered an avoidant behavior. So at what point would that be considered like bad for you?
That's a fair question, a good question. Anything is only bad to the degree to which it interferes with your function. Social functioning, work functioning, school functioning, social adherence, anything, right? So unless it's causing you distress and interfering with function, it's not a problem, right? That's how we define it. That's how we ultimately, when we're making a clinical diagnosis, you're always going back to, is this a problem for the person? If it's not a problem for you, it's not a problem. So that brings us to, is it adaptive and is it helpful? So does distraction work for you?
It does. Yeah, it does.
Do more of it then, if it's
Okay.
not interfering with your functioning in any
Okay.
way. And so distraction is a key coping. Remember I mentioned coping skills training? Distraction is one of those. It's a great strategy if it works. If it doesn't work, move on to something else. But again, it's a good question, because at what point, you hear, oh, don't, you're avoiding, and no, you're not. You're taking care of yourself if it's not interfering with your function.
Thank you.
Yeah.
We had another one that was sent in ahead of time that I wanted to bring up because some folks were talking about it in the chat too. And it's about, is there evidence around the effectiveness of being in a support group? For probably not aortic disease, but maybe health conditions in general or cardiovascular disease. They said, sometimes I find it really helpful to talk to other people who know what I'm going through, but I also think it leads me to be more anxious sometimes and maybe get in a rut feeling sorry for myself.
Yeah, so that's a fantastic question, and it depends on the support group, right? Support groups can actually cause harm. As an example, you're feeling more anxious after it, and misinformation can be shared among support groups. So it's always important to pick the right support group, one hopefully that is led by people that are trained to lead them, or run by someone who's a healthcare worker with experience and expertise in this stuff. And so I tend to dissuade people from just a Facebook kind of support group when it's something as serious as aortic disease or cancer or any of the others, and lean on those support groups where they're actually facilitated by someone who knows what they're doing. And then if you are distressed, they can help get you to the right place. Yeah.
Thank you. Meredith, did you?
Yeah, I think another question that I had, and it was brought up in the chat, is what, if any, does faith play a role in mental health and after a huge, either good or bad? I had a crisis of faith after my aortic dissection. I'm not afraid to admit that. Where do you lean into that as a medical professional? Is it just kind of up to the person? Again, no size, nothing fits everyone. But what do you see faith playing a role, if any? We are not a faith organization, so this is really just a question that I saw in the chat.
Yeah, so faith is relevant to the degree to which it's relevant to the person, either as a way to cope or as a consequence. I've lost my faith, and if that's causing distress, well, then we need to address it, right? So faith is big; it's huge, depending on the person. Someone that has no faith, that isn't worried, is not even thinking about any of that, and then it's not relevant. But I would definitely, and I always lean on it or lean into it and encourage folks to lean into it if that's faith and it is a helpful way to cope. And again, or if the consequence is negative and that I've lost my faith, I hate God, which I've heard many, many times, then the degree to which we need to kind of just discuss that and work through that's all relevant stuff. It's part of it.
We are almost at the hour here. Do either of you see anything I've missed? I apologize if I have. The chat has been so interactive. So thank you all for sharing so much about your own journeys. We've had people sharing about care they've received, difficult mental health situations they've been in personally. So we really appreciate everyone being so open and honest and using their experiences to help others. But Meredith or Bella, do you have any last questions that
I just,
that are quick?
well, not questions, but in this last moment, I just really wanted to plug again. Again, Bella and I are also both affected. Ellen is my go-to guru. But a mixture of resources is needed. You're not just going to get everything from the John Ritter Foundation. You're not just going to get everything from your cardiologist. This needs to be a conversation in every health conversation you have, in conversations with your family, and find the resources that work for you. There's no, this is truly bespoke medicine. And I was talking to a woman and she was talking about her provider and she said, you might be an expert at aortic dissection, but I am an expert at Meredith O'Neill. And I think that that was a really powerful thing. So know thyself, know thy partner. And we do have great programs, but we also have partners with great programs. And I encourage you, if you haven't reached out to Aorta Advocates, to do so. If you're really struggling, we match you with people that are on the same path you are, who've gone through the same things that you have gone through, maybe not exactly, but can relate. So that's how I wanted to end before, Ellen, you wrapped us up.
Yeah, and everyone is saying thank you so much. Lots of good information, great information. This was wonderful. Someone has asked if you can be their doctor. So you may have gotten some new patients. But I did want to ask you all if you're willing to fill out a survey. That will be the end screen when the webinar ends. That gives us feedback on this webinar. We really appreciate anything you have to share with us so that we can make improvements and provide more resources and speakers that are relevant to you and your lives. And I think that might
I
be...
have one thing.
Bella's got
I'm
one
just
more thing.
finishing this chat. I'll just answer this one verbally. The webinar will be available on our YouTube page once the recording is available, and then all of you who are registered will be receiving the link once it's ready as well. So you'll be able to watch a replay of this. I also wanted to address a question that somebody had asked if John Ritter Foundation has a list of support group resources. I mentioned maybe contacting Aortic Hope because they might be able to have like local chapters or groups of people who are part of Aortic Hope and Connected that they can connect you with. But also ask your local hospital, your surgeon, your cardiologist if they know of any groups that their patients have put together. So those are some avenues where you could find some local groups. And then, as Ellen and Meredith have mentioned, we do have the Aorta Advocates. We also have Aorta Prep. So anybody who has an upcoming appointment, who's had a dissection, an aneurysm, is a caregiver for somebody who's going through one, you have a free virtual session with myself, and we kind of parse out what you know, what you don't know, your concerns, and we get you ready for that doctor appointment so you can take your questions to the doctor's office and get those addressed in your concerns. So I am trying to share the link to our website where if you can, if you want support, we don't know what you're looking for, you're interested in everything that we offer, fill out this form and then we'll get back to you and try to direct you to wherever you're needed. We'll direct you to Aortic Hope if you want, but any specific questions we didn't get to address during this webinar, also we can help you if you reach out to us.
Okay, thank you so much, Bella, and great thank you to Dr. Ashmore again. That was wonderful. I will send you all the nice messages so that you can read them yourself in the chat and improve your own mental health by getting all these wonderful compliments. For our presenters, if you can click the little enter backstage box, that would be great. And we'll have a little debrief, but for everyone else, thank you so much. And we will see you at the next webinar, and we appreciate your attendance today.